So next up, we'll hear from Russell Rothman, who's the Director for the Center for Health Services Research and Chief of Internal Medicine Pediatrics at Vanderbilt.
Have some slides. Good morning. I'm going to give a presentation today about where we are with PCORnet, which Rob mentioned this morning as an opportunity to hopefully help support real-world evidence research. So this is a national patient-centered clinical research network that was funded by PCORI really to help support national comparative effectiveness research and pragmatic clinical trials. The network consists of 20 patient-powered research networks that represent many common and rare diseases, as well as 13 clinical data research networks. And those 13 clinical data research networks have a broad reach across the country. So we basically have representation in pretty much every state in the country. This represents over 100 healthcare systems and organizations across the country. And it's not just academic medical centers. It includes community health systems, community health clinics, private practices, a broad array of both inpatient and outpatient facilities. And at each of those sites, we have built data marts to pull data from electronic health records and other sources into a common data model. So we have over 80 data marts across the country that are pulling in data. Currently, about 70 of those are certified data marts that can run queries. And this is just an example within our own clinical data research network where we have 7 different data marts. All of those data marts have pulled in electronic health record data from their health systems and other data sources, have put those data into the same common data model. So all 70 or so of these certified data marts across the country have their data in the same format in this common data model, and we're able to run queries nationally to address questions or even to potentially identify patients for research. So currently we have electronic health record data on over 110 million patients from across the country. These are the elements that are currently in the common data model. We will be expanding on this over time, but you can see we have a lot of common data elements, diagnosis codes, procedure codes, lab results, prescribing and dispensing data, vital signs that can be used to identify patients with particular conditions, to follow patients over time, and for clinical research. In addition to the data that we get from electronic health records, many of the CDRNs are also working to link that electronic health record data to other data sources so that we can get a more complete picture of our patients for research purposes. And this is something that was touched on a little bit earlier this morning. We currently have a lot of research that only looks at EHR data or that only looks at claims data, and there's huge gaps when we only have access to one of those data sources. So we're really trying to connect the two together and get a much more complete picture, and that's being done through linkages to state health data such as all payer claims databases, state vital statistics such as birth and death certificate data, Medicaid data, Medicare data, and also data to private health plans. We actually currently have partnerships with Anthem and Humana nationally, but also many of us have linkage to local health plans in our regions. We have linkage to National Death Index data, and many of us also have linkage to biologic and registry data such as cancer registry data or genomic data. So really trying to create a much more robust infrastructure for real-world research. We've also built tools to better identify and contact patients for research, so tools that allow us to run queries and identify patients who are eligible for research, and tools to actually contact them in novel ways through email, through text, through phone, through patient web portals. We've built out some electronic consenting processes, expanded survey tools for collecting PROs, and even electronic payment processes. We've also been working on creating some administrative simplicity. So you heard some frustrations this morning about dealing with so many different contracts, so many different IRBs, and we have been working across the network, across all of these health systems, to have shared administrative simplicity. We've all signed a data sharing agreement for data sharing already. We're all piling on to the NIH Smart IRB process, so we're pushing for a single IRB approach, and we've been doing work to create master contracts to ease research across the network. Stakeholder engagement, as in all PCORI-funded initiatives, is of huge importance. We engage stakeholders, including patients, clinicians, and health systems, in all of the work that we do in advisory roles, as patient co-investigators on oversight committees. We get input for research ideas from our stakeholders, and we also involve them in review of proposals to ensure that the patient voice and the clinician voice is part of the process, both in the development of research, the conduct and implementation of research, and in the dissemination phase. So these are the types of research that PCORnet can support. We can do pre-research, just run queries for you, how many patients with a certain condition are on a certain medication, for example, or help to reach out to the practices and systems participating in the network. We can do observational studies looking at our data over time, including comparative effectiveness research, but we also can do intervention studies, particularly pragmatic clinical trials. We can talk more in the Q&A about the role with industry in terms of phase 4 trials versus even potentially some phase 3 trials. And this is just an example of something we did just at one site at Vanderbilt, where we were identifying patients who met criteria for a weight study. We identified several 100,000 patients. We contacted over 10,000 through email. If they were interested in the study, they put in their name and their date of birth. It checked to see if they were eligible for the study. If it was, it took them to an electronic consent form. And then once they consented, we did a survey and we linked that data to their electronic health record data. And using this process, we were able to survey over 10,000 patients in a very short amount of time across multiple health sites. And we also, in a sub-study of that, took 400 of those patients and invited them to participate in a mobile phone study where for each meal, we linked to their GPS in their phone. We had them report what they were eating, and we collected some data about their emotions while they were eating. And you can see in a 2-week period, we collected data on over 11,000 meals, a little bit Big Brother, and you know, this is Nashville. We know when you went for barbecue. So it was a really fun study, and I think you're going to hear more about mobile applications, and there's a lot of opportunity there to collect additional data. Rob mentioned this morning this idea of building computable phenotypes to identify patients with certain conditions. This is a project we did to identify patients with coronary artery disease. We built an algorithm to identify patients within our system. We identified over 30,000 patients that had known coronary artery disease, that had contact with our system over the past few years. And you can see we were able to identify those patients with very high sensitivity and specificity when we did chart review. Currently, we have several large demonstration projects going on nationally to demonstrate the robustness of PCORnet. This is a project that's being done nationally with data marts from across the country, looking at the comparative effectiveness of different approaches to bariatric surgery and looking at outcomes from electronic health record data on weight status, diabetes metrics, adverse events of patients identified. We've been able to identify over 50,000 patients who have had bariatric surgery across the country, and now we're looking at that data to look at their outcomes over time. This is a second observational study we're doing right now that's looking at the relationship between antibiotic exposure and obesity in the pediatric population. There's been some initial studies suggesting that higher exposure to antibiotics is actually associated with more weight gain. And we're again able to identify children across the country from our electronic health record data and look at whether or not they were given antibiotics and look at their weight trajectory over time. But as I mentioned, we're also able to perform intervention studies. And the big one we're doing right now is the adaptable trial, which is a pragmatic randomized clinical trial looking at the optimal dose of aspirin for patients with coronary heart disease. We've been giving aspirin to patients with coronary heart disease for years, and we still don't know what is the optimal dose. Should you be on 81 milligrams of aspirin or 325 milligrams, balancing the benefits versus the risks of that therapy? So we are using our common data model and electronic health record data to identify patients who are eligible for the study. We're approaching them predominantly electronically. Once we identify them, we send them to a website where they go through an e-consent process, and they get randomized either to baby dose or regular strength aspirin, and then we're following them predominantly electronically, pulling data from their electronic health records and from claims data to see what happens to them over time, as well as collecting patient-reported outcomes from them, following them for 2 years to look at these endpoints. So this study really shows how we're maximizing the use of electronic methods to do pragmatic clinical trials, as I mentioned, electronically identifying patients, using electronic methods to capture data over time, both directly from the patient and from health records. This really is a pragmatic trial, so there's minimal, there's identification of patients through electronic records. There's very broad inclusion criteria for who's participating in the study. We've had a lot of patient engagement in the design and implementation of this study. I mentioned the e-consent and collection of data, and you can see we're doing it at a very reasonable price. So we think this study demonstrates our ability to be able to perform these large pragmatic trials with a lot of efficiency by taking advantage of electronic health data and electronic tools for research, and hope that this will be a novel and exciting way to do a lot of additional studies in the future, particularly in this real-world evidence space. And I'll just give one more plug and say the front door for PCORnet is now open. If people are interested in trying to run queries or to use the network for observational or interventional research, we'd be happy to start that discussion. Thank you.